Hey everyone. Today we are going to talk about blood vessels and circulation. So, we're mainly going to be talking about arteries versus veins. How are they alike? How are they different? And then we're going to talk a little bit about how blood moves through the body. So, let's recap what we've covered so far because previously we've talked about the blood and we've talked about heart anatomy and function. So you'll remember, obviously, that the heart pumps blood and it's going to do that through a series of arteries, capillaries, and veins. So you learned that blood exits the heart heading out towards the body via the aorta, and it's going to return from the body's tissues via the vena cava. And in between are where the blood will pass through the capillaries, and that diffusion of nutrients out and waste into the blood will happen in those capillary networks. So, just a reminder that our heart has two major circuits that you should be familiar with: the pulmonary circuit, which is going to focus on the connections to the lung, and then also the systemic circuit, which is focused on connections to the body. So when we think about the pulmonary circuit, we want to think about blood leaving the right ventricle, out the pulmonary arteries, heading into the capillary network in the lungs to pick up oxygen, and then returning to the heart via the pulmonary veins into the left atrium. And on the other hand, in the systemic circuit, we're going to see blood leaving the heart from the left ventricle via the aorta. So this is oxygenated blood. It's going to head out into the arterial networks, eventually reaching the capillary network. And then from there, the veins will pick up that blood from the capillary beds and return it to the heart via the vena cava into the right atrium. So, sort of two major circuits there to make sure we pay attention to. Now, in both of those circuits, we have arteries and veins. So let's talk about the general blood vessel classes. So obviously we have arteries, and that's going to include both elastic and muscular arteries. So these are large arteries, including the aorta exiting the heart. And then we're going to have arterioles. Then we'll have our capillaries. They will become venules, which will become veins and return back to the heart. So in our chart over here, we can get a nice broad overview of the differences between a typical artery and a typical vein. But let's just remember that within each of those major classes, there may be some tweaks to these characteristics. So when we look at an artery in a sectional view, typically arteries are round. They usually have a pretty thick wall and they have a relatively small lumen. Veins, on the other hand, are not normally round. They tend to be collapsed or flattened. They're usually pretty thin walled, and they actually have quite a large lumen. Now, keep in mind that it's probably going to be collapsed, so you're not necessarily seeing a giant round looking structure, but if you were to open it up, you would notice that that lumen was much bigger than the lumen of the artery. Now, we have three layers that we typically associate with blood vessels: the tunica intima, like intimate, so the innermost one; the tunica media for middle; and then the tunica externa, which will be the layer, right? A tunic is a layer on the outside, or the external layer. So when we think about tunica intima, we are going to see an endothelium in arteries and veins. And in veins, that endothelium, which is really just a simple squamous layer of epithelium, is typically smooth. On the other hand, in an artery, it may look kind of rippled because of the constriction of the arteries themselves. The muscle within the arteries is often constricted, which creates a rippled or wrinkled effect of the endothelium. In arteries, we are going to see an internal elastic membrane. So we're going to see a lot of elastic fibers and this connective tissue layer that's going to give some stretch and bounce to the artery, whereas we're not going to see that in your typical vein. In the middle layer, the tunica media, our arteries are going to typically have a thick, smooth muscle layer as that middle layer, and it will have elastic fibers in it, whereas in our more typical vein, that media layer will be a lot thinner. We are going to have some smooth muscle cells, but we're not going to see elastic fibers as much as we see collagen fibers for strength. There is also in that middle layer in arteries, we're going to see an external elastic membrane. So, kind of a repeat of the internal elastic membrane, that kind of stretchy rubber band like connective tissue. But in veins, we're not going to see that. And then in our outermost layer of arteries, we're going to find that that externa has a lot of collagen and elastic fibers, which is similar to the vein, but in the vein, we may also find some smooth muscle cells there. So those are just the three major layers that we find often, and there are going to be exceptions to this in blood vessels and how they are either alike or different in your typical artery and typical vein. But again, we're going to have all these categories that we're going to talk about, and we will see differences among the categories. So here's just an image kind of showcasing the primary differences between an artery and a vein. So right off the bat, you can see how the artery wall is a lot thicker than the vein. I think the tunica media really stands out in the artery versus the much thinner layer of muscle in the vein. We're also going to see that ripple effect of the endothelium in the artery where it's a little smoother in the vein. And then we should be able to see our external elastic membrane and our internal elastic membrane. They don't really jump out at you in these diagrams, but they are there and they are labeled. And then of course, both are going to have that tunica externa as well. Again, pretty similar, but we're more likely to see some smooth muscle mixed into that tunica externa of the vein, whereas we wouldn't see that in the artery. In this actual micrograph here, and let me just see if I can, I don't know, my computer is fighting me here. There we go. It's a little bit bigger. You can see how we have a nice round artery here, but this is a little less round. But you can also clearly see that the lumen of this vein is significantly larger than the artery. This is going to create more resistance, which is going to help blood actually move through more quickly. Whereas the lumen of this vein is going to be really good for just holding larger volumes of blood. But it's not necessarily going to flow through really quickly. All right, if we can get back to normal size, there we go. So digging in a little more on arteries, again, they're typically round, typically thick-walled with a small lumen. Over here, you can see an elastic artery like the aorta versus a muscular artery, which is the arteries that would come off the aorta, think common carotid. And then arterioles, which are the branches coming off of those. So you can see a change in size, but we're also going to see a change in anatomy as well. So again, our elastic arteries are going to be very large vessels like the aorta and the pulmonary trunk. They have really good stretch and recoil, which is going to help push boluses of blood through these large arteries. The muscular arteries are going to be those arteries that are actually routing blood towards muscles and organs. They tend to have very muscular walls relative to the elastic arteries because these arteries are going to be capable of vasodilation, increasing the size of the lumen, or vasoconstriction, decreasing the size of the lumen. And then you can see the arterioles really look a lot different. So these are getting a lot smaller. These are going to give rise to the capillary beds. There is essentially almost no tunica externa here and just sort of scattered muscle cells. And of course, they have an endothelium to line the inside of that lumen. When we get to the capillaries, so these would be the branches of arterioles, we're going to see that we have no tunica externa or tunica media. So really, we're just left with an endothelial lining, or the tunica intima, essentially, because these are the vessels that permit exchange of nutrients and waste products between blood and the interstitial fluid of your tissue. So we want that really thin wall for that diffusion to be able to take place and to take place quickly. And also kind of interestingly, there are two kinds of capillaries. We're going to have fenestrated capillaries. These are going to have pores through the endothelial cells. And so there can be movement through those pores of materials or molecules. Whereas continuous capillaries, they're going to be a little smoother. They're not going to have those pores, but diffusion can still take place across those endothelial cells. It's just that fenestrated capillaries are going to have a particular kind of function, and we'll find them in particular locations, for example, in the kidney. And continuous capillaries are going to be the kind of capillaries that maybe you think of more traditionally when you think of a capillary network. So if we look here, this is sort of your typical capillary bed. So we can see here are our arterioles coming in and supplying blood into this capillary bed. The capillaries are where exchange will happen. So, oxygen and glucose out, for example, into the surrounding interstitial fluid. Waste products will move in. And so, that deoxygenated blood, along with those waste products, will be collected and drained into small venules, which will eventually come together to form veins and ultimately return to the heart via the vena cava. There are some interesting things we just want to note here. There are precapillary sphincters. So these are little smooth muscle cells that surround this branch, which means it can be constricted or relaxed to either reduce blood flow or increase blood flow into that capillary bed. And you'll notice that there's quite a number of them. There are also some through channels that are going to help blood move a little faster versus these sort of diversion channels where blood is going to flow very slowly and allow time for diffusion. And we'll also have some arteriovenous anastomoses. Anastomosis is just a very fancy word for connection. So this is a direct connection from an arteriole over to the venule. Blood can move quickly here, bypassing the capillary network. For example, if you are fighting a bear, you really don't need to be worrying about absorbing nutrients from, your lunch. So you may have those precapillary sphincters constrict and reduce flow of blood into the capillary networks temporarily while you're fighting the bear or running from the bear. And instead, we're going to just move that blood right through so that it can be rerouted to the muscles where you might need that blood a little bit more in that moment. Okay, veins are also going to come in a variety of styles. So again, they're going to be flat, thin-walled, large lumen typically. If we start down here in our smallest venule, you're going to see there really is no tunica media. We just have that tunica externa surrounding an endothelium. These venules are going to collect blood from our capillaries and then ultimately join together and dump it into medium-sized veins. These will have all three layers, a tunica externa, media, and intima with the endothelium. And then these medium-sized veins will gather together to form larger veins, which again will have all of the layers, and the vena cava is a great example of a large vein. All right, so how can blood vessels impact cardiac output? Well, here's the thing. All those miles of blood vessels in your body create friction, right? Blood is running along, it's hitting the walls of the vessels, and that creates friction. And so we call that peripheral resistance. And there's actually a number of things that will lead to peripheral resistance. So the smaller the vessels are, the harder it is for the blood to flow through. It might be able to go through faster, but it's going to hold less blood, and it's more of the volume of blood will be touching the walls of the vessel, which would increase friction or resistance. How long the vessel is. The longer the vessel is, the greater the resistance will be. How thick the blood is. So the thicker or the more viscosity the blood has, the harder it will be to move it through the vessels. And then also turbulence. So every time there's a connection between vessels, so think of it like when you have streets and there's an intersection, at each intersection, there's some turbulence, right? Like traffic slows down and people are turning and it's all kind of swirling around at that intersection. And so things don't move quite as quickly. And blood is exactly the same way. So again, the four components that will determine peripheral resistance will be how big are the vessels? What's the diameter? Tiny, medium, large. How many feet of vessels do we have? The longer the length of the vessel, the greater the resistance. How viscous the blood is. So if you're dehydrated and you don't have as much water, that's going to make it more viscous. If you are really hydrated, it might be a little less viscous. And then how much branching is going on is going to impact turbulence. So all four of those things can increase peripheral resistance. Also, how much blood is being returned, right? Your heart can't pump more blood than what's coming back to the heart. So the venous return is going to be really important. The more blood that comes back to the heart, the more the heart can pump in terms of output. Resistance, that peripheral resistance, decreases as you get closer to the heart, because think about it. The veins have large lumens, and there's going to be less turbulence. The vena cava are relatively short, so that's less vessel length. And so overall, we see less resistance, which helps to increase return. Okay, so this is also connected to blood pressure. So the more resistance you have, the higher your blood pressure might be, for example. But blood pressure isn't constant, right? It's going to rise and fall as arterial walls stretch and recoil. So we measure blood pressure as systolic pressure over diastolic pressure. So what do we mean by that? Well, systolic pressure is the peak pressure during ventricular systole. So systole means contraction. So when the ventricles contract, when they are at their peak contraction, that is systolic pressure. And then diastolic pressure is the minimum blood pressure during ventricular diastole, and diastole is relaxation. So when the ventricles relax, when they are their most relaxed, whatever that lowest pressure reading is, that's our diastolic pressure. So we put our systolic over our diastolic, and we call that blood pressure. So for example, 120 over 90. Our peak pressure is 120, and our diastolic or minimum blood pressure is 90. And that's a 30-point spread, and that's pretty good, pretty normal. Some people might be 100 over 60. That's okay. Any lower than that, we probably are a little bit like, And if it gets too high, you start hitting the high 130s, 140s in that systolic, and we start wondering what's going on there too. There's going to be variations with age and individuals, so we have to keep that in mind. Now, there's a few other things that we need to know about when it comes to blood pressure. There is something called pulse pressure, and that's just the difference between systolic pressure and diastolic pressure. So to calculate pulse pressure, you literally take the difference between them. So if you have 120 for systolic and 90 for diastolic, the difference between them is 30. So the pulse pressure is 30. So that's pretty easy. Now, we also sometimes are interested to know what the mean arterial pressure is. In other words, what's the average arterial pressure across the body? Keeping in mind that, elastic arteries and our muscular arteries and arterioles are going to have different blood pressures. So we're looking at getting an average of them. So to figure out mean arterial pressure, we're going to take our pulse pressure and we're going to take our pulse pressure, figure out what 1/3 of that is, and then we're going to add that to our diastolic pressure, and that will give us our mean arterial pressure. So what we see down here in this little equation, right? So right here it says add 1/3 of pulse pressure to diastolic pressure. So our diastolic pressure is 90. So to figure out MAP, we're going to take our diastolic pressure, which was 90, and we're going to add 1/3 of the pulse pressure. Well, pulse pressure is the difference between SP and DP. So that's 120 minus 90. That's pulse pressure. And then we only want 1/3 of it. So we divide it by 3, and that will give us our mean arterial pressure. And if you do this math, it comes out in this example to 100 millimeters of mercury. So that would be our mean arterial pressure for someone whose blood pressure was 120 over 90. But if this was 110 over 80, then you would have 80 here, and then you'd have 110 minus 80 divided by 3. So this is an easy thing to figure out once you know the formula. All right. So your blood pressure is constantly being monitored by your nervous system. It's kind of important for homeostasis, right? You kind of need your heart pumping out enough blood to meet your bodily requirements for oxygen and glucose and everything else. So your nervous system has a few ways to monitor your blood pressure. One way is through baroreceptors, which are located in places like the carotids and the aorta, and they are checking blood pressure constantly and communicating with the brain. We're going to have cardiac centers in the medulla oblongata. So that's where that information is being integrated and processed. We are also going to have chemoreceptors in your blood vessels that can detect changes in chemicals like CO2. If CO2 is getting too high, that's going to be a concern for your nervous system. And of course, chemoreceptors could detect changes in O2. Is it high? Not usually an issue, but is it low? Definitely an issue. And also pH, because pH is a litmus for CO2. If pH is decreasing, that would suggest that CO2 is increasing. Because when CO2 is in the blood has a lot of water. When CO2 is in water, it forms carbonic acid. Acids are going to lower pH, and we don't want our blood pH levels to shift too much. There is a very narrow homeostatic range for blood pH, otherwise it will affect enzyme function by denaturing them. So we are constantly monitoring that as well. The endocrine system also monitors your blood pressure. So there are going to be cells inside the kidney that are monitoring the volume and pressure of blood coming into the kidneys. And they can do things like release hormones such as renin, angiotensin, and aldosterone, which can help increase blood pressure. And also EPO, or erythropoietin, which we've talked about previously, and its role in red blood cell formation. So we've got both a short-term response system, that's the nervous system, and a long-term response system, which will be the endocrine system, monitoring and ensuring homeostasis of blood pressure. So I thought you might like to see what what cardiac output looks like at rest versus light and heavy exercise. So when you are at rest, you can see your cardiac output. In this example, they're going with 5,800 milliliters per minute. And you can see that most of that blood is actually going to, for example, your skeletal muscles and your abdominal viscera, because your organs are doing a lot of work when you're at rest, right? So we want good chunks of blood going to these major organ systems so that they can do their regular job. And there's also a good old chunk of it going up here to your brain, because your brain just has a high rate of metabolism all the time. Now, when you start to exercise lightly, we will boost cardiac output, and you'll see that the vast majority of that boost in cardiac output is going to go to skeletal muscle. That makes sense. Light exercise means you're using your skeletal muscles. They're going to need a little more oxygen and a little more glucose. You'll also notice that we see a reduction in the blood that's going to your major abdominal organs like kidneys and the other abdominal viscera, digestive system, things like that. And then maybe if you're really paying attention, you'll notice that the amount of blood going to the skin increases, and that's going to help us thermoregulate, right? As we use these skeletal muscles, we're going to generate heat. We want to try to moderate the impact of that heat by releasing some of it, by routing blood out to the skin in order for that heat to be lost, right? Now, when we start exercising, like we're really pushing it, now what happens is we can, again, dramatically increase cardiac output. So, I mean, we've gone to 17,500 mils here per minute. So this is a huge increase. We are dumping the vast majority of that into our skeletal muscles, but we are still dumping a lot out to the skin to deal with this excess heat issue, but we are significantly reducing what we're sending to our other organ systems. But notice what stays steady is the amount of blood to the brain, because neurons always need a certain amount of glucose and oxygen to do what they do. So that one we want to keep the same. So that's a good overview of what happens to cardiac output as you increase activity and how your body routes that blood to meet the needs. All right, so what happens if blood pressure drops due to a loss of blood? Well, that would be detected by baroreceptors and chemoreceptors in the nervous system, which would immediately activate sympathetic nervous system responses in and the cardiovascular centers in the medulla oblongata. So two sets of brain locations are going to be like, whoa, something's going on here. And that's going to lead to vasoconstriction, because if we decrease the volume of the blood vessels, that will automatically increase blood pressure because there's less space for the blood to occupy. So that's going to create more of a push outwards on the walls of the vessels, which increases blood pressure, but it's not increasing overall blood volume, right? That's the key there. We also can mobilize any reservoirs of blood in the venous system. So your veins have large lumens. They can store quite a bit of blood there that's not necessarily moving through very rapidly, but we can mobilize it and get it out into the arterial system. And we can also increase cardiac output. So we can increase cardiac output by increasing the number of heartbeats per minute and also by how much volume is in each stroke. So when that left ventricle contracts and pushes blood out into the aorta, what's the volume of that blood? If we can increase that, then that can help increase blood pressure. But that is going to mean we have to return more blood to the heart, which is why we want to mobilize those venous blood reservoirs. Now, the endocrine system is also going to detect the change in blood pressure. So we're going to see a release of antidiuretic hormone, angiotensin, aldosterone, EPO are all going to be secreted. These all have the goal of increasing blood pressure. We're going to hold on to water, and we are going to start the process of making more red blood cells. These are somewhat longer term responses. They're not going to be short term effects. If we aren't able to get that blood pressure back to normal homeostatic range, the individual may enter shock, which creates a cardiovascular crisis due to hypotension. That's just another way of saying low blood pressure and inadequate peripheral blood flow. In other words, we are not adequately meeting the needs of the body's tissues. And so not enough oxygen, not enough glucose is getting out to the cells, and not enough waste products are being picked up. And that can lead to death if not corrected. So here we're just seeing all of this kind of brought together into a diagram. So over here, we can see homeostasis has been disturbed by decreasing blood pressure and volume. And in this situation, they're saying that that's being caused by extensive bleeding. So that's our stimulus, is low blood pressure and volume. What that will trigger is the nervous system and the endocrine system. So receptors in the nervous system, baro and chemoreceptors, are going to activate centers in the brain, in the cardiovascular center, and also just general sympathetic activation of the autonomic nervous system. And then also that decreasing blood pressure and volume will be detected by receptors in the kidney. And as I said, that's going to increase the long-term hormonal response of ADH, angiotensin, aldosterone, and EPO. So coming back to the brain with the cardiovascular center and sympathetic activation, that will have a very short-term impact of increasing cardiac output, mobilizing those venous blood reservoirs, and constricting blood vessels in the periphery to try to increase blood pressure, leading to increased blood pressure and blood volume. And hopefully that allows us both in the short and long term to restore those lowering blood pressure and blood volume issues and get this individual back to normal. However, while this seems very easy and tight, there's a little bit of an issue here, because when we have decreased cardiac output, so we've got a severe reduction in blood volume, that's where we're starting. That leads to a decreased cardiac output. If you have decreased cardiac output, one problem is there's going to be less blood flowing out the coronary arteries to feed the muscle of the heart itself, which in turn can lead to damage of those heart muscle cells, which means we will then have even less cardiac output. So this is a positive feedback loop right here. Also, that decreased cardiac output means we have decreased arterial pressure, which means we have decreased peripheral blood flow, which means we're going to see an increase in carbon dioxide and lactate and decreased pH, which in turn leads to clotting within the vessels, which further decreases peripheral blood flow. So once again, we find ourselves in another feedback loop. And those increased CO2 and lactate and decreased pH of the blood is going to cause capillaries to become more permeable, which means things are going to be exiting out of the capillaries, which is going to reduce blood volume even more, which creates another positive feedback loop. So we've got 3 positive feedback loops as a result of loss of blood volume, all of which are taking us further away from our normal homeostatic range. And if we can't interrupt all of those positive feedback loops, then what's going to happen is over here in purple, we're going to see maximum vasoconstriction, irreversible cardiac muscle damage, which ultimately will lead to decreasing arterial pressure and circulatory collapse, which will lead to death. And you can see we even have, just as an added bonus, another positive feedback loop here. As a result of decreasing arterial pressure, we're going to get decreased flow to the brain, which will lead to brain damage in the central nervous system, which will lead to decreased sympathetic activity, which is going to impact all of these things over here. So it's going to be even harder to restore. So when we have someone that is exhibiting decreased blood pressure and volume, it's these positive feedback loops that we have to intervene in order to prevent them from heading into this territory where we're just beyond intervention here. All right, and that is it for this chapter.